Hello, everyone. Welcome back to PodBites, where we break down complex medical topics into bite sized pieces, perfect for your commute, coffee break, or whenever curiosity calls. I'm Lamar Antari, your host for today's episode, and I'm accompanied by Leen and Al-Fadhel to take a journey into the world of pharmacology.
Hey guys, let's start with a story. Meet Lucy, a creative, imaginative young person who always saw the world a little differently. But in late adolescence, something changed. The voices weren't just imagination anymore, they were intrusive, loud, frightening. Lucy saw help and was diagnosed with schizophrenia. With treatment, the hallucinations softened. The chaos quieted, but the journey didn't end there. Medication helped, but it also brought weight gain and self esteem struggles. And that's what today's episode is all about. Not just drugs, but balance, mechanisms, side effects, and real human lives behind prescriptions.
That's right. Today we're discussing antipsychotics, which is ironic with how we drive each other psycho, because I love pharma, unlike Leen. But first, let's talk a bit about what Lucy has.
Schizophrenia is a chronic psychotic disorder that affects how a person thinks, feels, perceives reality, and interacts socially.
It typically begins in late adolescence or early adulthood and affects about 1% of the population worldwide. We divide symptoms into three main domains. Can you go over them, Leen?
First, we have positive symptoms, where something is added. These can be delusions, hallucinations, catatonia, etc. Then we have negative symptoms. Here, something is loss of motivation, loss of pleasure, social withdrawal, or even flattened demeanor. I'll leave the last one to you.
Fine. Finally, we have general cognitive symptoms like impaired attention and a poor memory.
Now that we know the three domains, the main thing to keep in mind is that positive symptoms are the easiest to treat. Negative and cognitive, so much harder. Before I walk you through the pathways, which are the main players here after all, can you go over the functions of dopamine?
Sure thing. Dopamine's functions can be remembered by DA ramp: reward, attention, movement, pleasure.
Okay, now let's get to the pathways. We have four major ones. First, the nigrostriatal. This one is for movement. Next is mesolimbic, associated with emotion and positive symptoms. We also have the mesocortical with motivation and negative symptoms.
And finally, the reason why labor ward nurses love to ask the mother to hold her newborn baby: the tuberoinfundibular pathway, which regulates prolactin.
For schizophrenia, we have the dopamine hypothesis. This states that an increase in dopamine in the mesolimbic pathway gives the positive symptoms, whereas a decrease in it in the mesocortical pathway gives negative symptoms.
And this hypothesis isn't from thin air. We have evidence, receipts to back them up. When we give dopamine agonists, like amphetamines, the psychosis worsens. On the other hand, when we use D2 blockers, we see an improvement in hallucinations and delusions. That's not the whole story, though.
Beyond dopamine, the glutamate hypothesis suggests that NMDA receptor hypofunction is what contributes to schizophrenia.
PCP and ketamine, both NMDA antagonists, produce schizophrenia-like symptoms. Also, genetic polymorphisms in glutamate pathways are associated with an increased risk.
Serotonin also plays a role, especially in negative symptoms. The bottom line is that schizophrenia is neurochemically complex.
Yes, this is a pharma episode, unfortunately for you, Leen, but we must also shed light on the non-pharmacological interventions. Do note that outcomes are best when we combine medication with cognitive behavioral therapy, cognitive adaptation training, and psychosocial support. People are more than receptors after all.
Well said, well said. Besides, antipsychotics are not curative. They reduce symptom intensity, yes, and they help individuals function independently. They take weeks, up to 6, to show full effect.
We have two major classes: the first generation, or typical antipsychotics, and the second generation, or atypical antipsychotics.
For the first gen, we have chlorpromazine, haloperidol, and fluphenazine. Chlorpromazine is low potency, whereas haloperidol is higher in potency. The main mechanism here is competitive D2 receptor blockade. Positive symptoms improve, but negative symptoms are minimally affected.
They also come with a few adverse effects, the first being extrapyramidal symptoms. When we block dopamine, we also block it in the other pathways. When it's blocked in the nigrostriatal pathway, we can see acute dystonia, akathisia, Parkinson's, and tardive dyskinesia. The last can even be irreversible. To treat these, we use anticholinergics like benzotripine.
We can also see hyperprolactinemia due to a blockage in the tuberoinfundibular pathway. This can cause galactorrhea, infertility, and sexual dysfunction. We can also see sedation due to H1 blockade. This is seen mostly with chlorpromazine and orthostatic hypotension due to alpha-1 blockade.
And rare, yet quite life-threatening, is neuroleptic malignant syndrome, or NMS. This can cause hyperthermia, rigidity, autonomic instability, and elevated CK. We see this most with high-potency drug like haloperidol.
Moving on to our second gen, which work mainly by blocking D2 and serotonin 2A receptors. These include risperidone, quetiapine, clozapine, and aripiprazole. Usually, these are our first liners.
They treat positive symptoms well, have a much better effect on negative symptoms, and come with a much lower risk of extrapyramidal symptoms. There's a trade-off though.
Instead of movement disorders, we get weight gain, insulin resistance, hyperlipidemia, and even diabetes. Metabolic syndrome becomes a big concern of ours.
Before we move on to some drug highlights, let's take a quick question. Rahumi is newly diagnosed with schizophrenia. Which of the following antipsychotic agents may have the best chance to improve his apathy and blunted effect? A. Chlorpromazine. B. Lufenazine. C. Haloperidol. D. Risperidone. E. Thioridazine.
And the answer is D. Risperidone is the only antipsychotic on the list that has some reported benefit in improving the negative symptoms of schizophrenia. It is a second-generation antipsychotic, and the other drugs are listed as first-generation antipsychotic agents.
On the topic of risperidone, as mentioned, it's second gen, so it blocks D2 and serotonin 2A receptors. It's great for positive and negative symptoms, but it can increase prolactin. Overall, it gives the best balance, but it's not EPS-free.
Quetiapine has a short half-life. We usually prescribe it to be taken twice daily. It can cause minimal EPS, but the most commonly reported side effects are sedation and weight gain.
Aripiprazole is interesting. It's a partial D2 agonist. It has a lower metabolic burden and can cause insomnia. Usually, it's associated with impulse control issues like gambling or binge eating.
And we have clozapine, our last resort. It's usually reserved for treatment-resistant schizophrenia.
It is quite risky, needing regular CBC monitoring due to the risk of agranulocytosis. It can also cause seizures, myocarditis, and severe weight gain. Yikes.
In general, note that all these drugs are highly lipophilic with a large volume of distribution. Some are even available as long-acting injectables.
Finally, we can use these drugs outside of schizophrenia, like with acute psychosis, nausea, and vomiting, and even intractable hiccups.
One last question to really solidify this all in. Rahumi now develops severe muscle cramps with torticollis a short time after drug therapy is initiated with haloperidol. The best course of action would be to A. Add risperidone to the drug regimen. B. Discontinue haloperidol and observe the patient. C. Give oral diphenhydramine. D. Inject benztropine. E. Switch the patient to flufenazine.
The answer is D. Alright, let's quickly wrap everything we talked about. Schizophrenia has 3 core symptom groups: positive symptoms like hallucinations and delusions, negative symptoms like apathy and social withdrawal, and cognitive symptoms like poor memory and attention. Positive symptoms are the easiest to treat, negative symptoms are the hardest.
The dopamine hypothesis is key. Too much dopamine in the mesolimbic pathway causes positive symptoms, while too little dopamine in the mesocortical pathway causes negative symptoms. And remember the 4 dopamine pathways: mesolimbic for emotion, mesocortical for cognition, nigrostriatal for movement, and tuberoinfundibular for prolactin.
First-generation antipsychotics like haloperidol and chlorpromazine mainly block D2 receptors. They're great for positive symptoms, but they don't help negative symptoms much and cause extrapyramidal symptoms from dopamine blockade in the nigrostriatal pathway.
Those extrapyramidal symptoms include acute dystonia, akathisia, parkinsonism, and tardive dyskinesia. Treat acute movement side effects with anticholinergics like benztropine. Also watch for hyperprolactinemia, sedation, orthostatic hypotension, and the dangerous neuroleptic malignant syndrome.
Second-generation antipsychotics like risperidone, quetiapine, clozapine, and aripiprazole block both D2 and serotonin 2A receptors. They treat both positive and negative symptoms and have fewer movement side effects.
But instead, they come with metabolic risks: weight gain, insulin resistance, hyperlipidemia, and diabetes. Clozapine is reserved for treatment-resistant cases but requires regular CBC monitoring due to agranulocytosis risk.
So, to emphasize some key points to remember, risperidone improves negative symptoms but can increase prolactin. Quetiapine causes sedation and weight gain. Aripiprazole is a partial D2 agonist with lower metabolic risk but can cause impulse control problems.
Clozapine is the most effective drug for treatment-resistant schizophrenia, but carries the highest risk, including agranulocytosis, seizures, and myocarditis.
And overall, antipsychotics work by reducing dopamine activity, especially in the mesolimbic pathway, which reduces psychosis. But blocking dopamine elsewhere explains almost all their side effects.
And finally, these medications aren't cures. They reduce symptom severity, improve functioning, and work best when combined with psychosocial support and therapy.
Block dopamine, reduce psychosis. But always remember, every pathway you block comes with a consequence.
And with that, we can finally conclude this episode on antipsychotics. I think I like pharma a little more now.
Yay, Leen! That's great. Thank you all for tuning in. Until next time.